another VMR session. It is great to see so many familiar faces today. And for those of you for who it's the first time joining VMR, welcome. You are officially stuck with us as part of the CPU Solvers family. I would love to hear if there is anybody who potentially has a case today that they would like to present. We are going to go with the format of, rather than having people formally step into the discussant seat, it's going to sort of be one big clinical reasoning session for us today. So essentially, everybody is welcome to share your thoughts in the chat, share how you're thinking about the case. You're welcome to unmute and share your reasoning out loud. I may ask people to unmute and share their thinking out loud if you do put something in the chat. There's never any pressure to do so. It's totally okay if I ask somebody to unmute and they're like, oh, I'm actually not in the place to talk out loud right now, or I would prefer not to share. That is 100% fine. My hope, and I think our hope in general in these sessions, is to get as many voices represented as possible and to get as many people contributing to the discussion, which is why we really encourage you to share your thinking out loud, including if your answer is, I'm not sure what's going on right now. Those are probably the 3 best words we can share in any case conference discussion. And so we'll leave a couple seconds for anybody to volunteer if they have a case. Well, we at least know Travis has a backup case. But if anybody has a case that they've been itching to present or that they've been excited to share with the VMR community, please do feel free to volunteer to present. I'm trying to tolerate silence. This has been a goal.
The silence always works.
All right, I cannot bear it any further. Travis, we will kick it over to you to be our case presenter today. And I'm just curious to see if there's anybody for who this is your first time joining VMR today. Xavier, I see. Was that a done? Well, Xavier, welcome. Thank you so much for being here. Do you mind unmuting and sharing a little bit more about yourself and where you're joining from?
Hello, guys. I'm Xavier. I'm in Boston. I'm a nephrology fellow, and I'm originally from El Salvador. Just excited to be here.
Welcome. It's great to have you here, Xavier. Thank you so much for joining us. Well, on that note, in terms of welcoming a new member of the community, why don't we go ahead and turn it over to you, Travis, to get us started with the case. And again, as Travis presents information, would love to see how you're thinking about the case via your thoughts in the chat, or if you want to unmute and share your thoughts out loud as well. That is absolutely welcome.
Perfect. And Bill, if you're on, you and I, we can present this case together if you want. So I'll lead it off. And the first aliquot, let me just pull it up really quick. So the first aliquot is the chief concern, and it is a 27-year-old male presenting with anorectal pain and bleeding. And I will leave it there.
So we have, I would say, would be maybe not the most typical chief concern here that we see, right? It's not one of the standard chief concerns like shortness of breath or abdominal pain. But I'm curious, just as people think in general about this sort of chief complaint of anal rectal pain and bleeding, what are some potential things that are coming to mind? I see Rafa mentioning hemorrhoids, STI, Xavier mentioning sort of abstracting this, what we have here into the term proctitis. Hans is mentioning an anal anal fissure here, as is Jasimran. And then Nathan is mentioning something really important here, which is what is the host immune status? Nathan, can I ask you to maybe unmute and share a little bit more, both about yourself, but also about what you're thinking here in terms of invoking the host immune status?
Yeah, hey everybody, I'm Nathan Works too. I'm a third-year resident at Baylor in Houston, from the Bay Area. So nice to see you guys. See you at the SFVA. Used to work there too. So
right on.
Yeah, so I think in my thought on this first is I think that's like my first major branch point. We have the symptom, but then also the person. And when I think about anorectal pain in a younger person, I think our common big buckets of cancer is a little, maybe less likely. But again, I think in my head, I'm like, well, who is this person and what other comorbidities do they have, or maybe we might not know about?
Yes, I think that's an excellent point, Nate, right? Like Nate highlighting here, one of the core elements of our problem representation, which is in addition to what is the clinical syndrome that we're dealing with, which Xavier highlighted brilliantly in terms of mentioning proctitis, Nate is having who is the person with the clinical syndrome. This becomes particularly important as we think about how we further narrow or expand our differential here, right? And so there are some chief concerns where we are going to take sort of a general approach, regardless of who the host is, right? And these are going to be things that have particularly severe conflict, right? Chest pain is chest pain because there's a list of morbid diagnoses that any individual could have that we don't want to miss. Whereas in other chief concerns, we may modify how we think about it, in large part due to who the host is. For example, febrile neutropenia, right? We still think about the common infections, but our DDX expands to include other diagnoses in a specific host that we may not think about in a different host. And so in this case, wondering what somebody's underlying immune status is incredibly important when we're thinking about this chief concern. And the reason for that is because it's going to expand the potential diagnoses that we bring into the fold, particularly infectious diagnoses. I see Gail mentioning thinking about IBD in the younger patient. Gail, do you mind unmuting and share a little bit more about sort of how you're moving from anorectal pain and bleeding into the diagnosis of IBD?
Hey guys, I'm Gail. I'm a second-year internal medicine resident at Ohio State. So just kind of thinking of the other big buckets of rectal pain, kind of like Nathan was saying, we have infectious, malignancy is a big one, particularly in older folks. A lot of times when I think of younger folks coming in with problems, autoimmune is another big bucket that I think about. So it kind of just drew me to IBD, which you also see sometimes a lot of time, you see rectal pain, anorectal pain, bleeding, more, sometimes even more common in the males. I know autoimmune is usually in the female population as well.
Excellent. I think that's right. So that is fantastic, right? So bringing in an entire category of disease here in terms of thinking about autoimmune or inflammatory conditions, which is brilliant. And then Sonia, I want to call out and see if you're comfortable sharing a little bit more, because I see you falling back on a very familiar framework for any chief concern that we see, which is an anatomical approach. So Sonia, do you mind unmuting and sharing a little bit more about what you just put in the chat, in addition to sharing a little bit more about yourself?
Sure. So I'm Sonia. I'm a room fellow at GW here in DC. And I guess when I'm in doubt, I tend to use this framework because I think about, like, I don't have as structured of a framework for specifically anorectal pain as I might for, say, like leukocytoclastic vasculitis, which is a little bit more in my wheelhouse. But I tend to at least try to think about what could be in the area where the patient is experiencing symptoms that could be affected and causing those symptoms. So in this particular case, I think I'm thinking less about categories of types of disease. So like less about inflammatory versus mechanical versus like other etiologies or pathophysiologies, because I just don't have as broad of a differential in that respect. but I am thinking about like, well, what is physically there? Is the mucosa the problem? Is it something superficial in the skin around the anus? Is it something that's a little bit deeper, like a blood vessel or a nerve that's causing pain? Is there muscular involvement? And so we need to think about something else that's potentially causing those symptoms. And so that was sort of how I started to try and parse this out.
Excellent. I think so. Absolutely brilliant thoughts here. And I completely agree. Whenever I don't have a well-developed framework that's not anatomical, that's exactly what I start to fall back on, because it's a really helpful checklist in terms of being like, I want to make sure that I'm not missing any particular organs or structures that could be a part of the problem here. So I think like that is both a brilliant point for this specific case, but also just a phenomenal reasoning point in general. Like when in doubt, if we can, fall back onto anatomy. I think just to sort of share a little bit in terms of where I'm going with this sort of initial question is I'm doing exactly what everybody who has shared their thoughts out loud is doing, which is sort of running a list of what are potential pathologies or problems that could cause these symptoms of anal rectal pain and bleeding. And I'm thinking about those things through the lens of who this host could be, right? So if we were to just review a schema of like what are some of, or how can we think about this finding of anal rectal pain and bleeding, I think one way that we can think about it is we could think about an anatomical approach, as Sonia mentioned, and we could sort of ask ourselves, well, gosh, what are the structures around this area that could have problems with it? And what could those problems be, right? We could have structural abnormalities that involve some of the vessels. That could be something like hemorrhoids. We could have structural abnormalities related to mucosal tearing, like an anal fissure, as many people have mentioned in the chat. We could have infectious or inflammatory abnormalities, like a perianal abscess or a fistula that could potentially have some bleeding associated with it. We could have an underlying malignancy in the area, like an anorectal cancer, oftentimes going to be related to HPV, or we may have the clinical syndrome of proctitis, which is inflammation of the rectum and the rectal mucosa. Proctitis in and of itself can be infectious or inflammatory in nature. Infectious causes of proctitis are going to include things like HCV, or HSV, gonorrhea, chlamydia, and potentially other sexually transmitted infections, as Rafa mentioned, or it's going to be related to underlying inflammatory bowel disease, as many of you have mentioned already, particularly ulcerative colitis, which can also manifest with proctitis or with a variant of ulcerative colitis, which is ulcerative proctitis. Now, this is where the point of who the host is becomes particularly important, as Nate highlighted for us, right? Gail brought in the important point of the fact that we may see an index manifestation of IBD, and then also understanding what this individual's immune status is and what other risk factors they may have for the development of some of these conditions. Individuals who have individuals who have receptive anal intercourse are going to be at increased risk for some of the sexually transmitted infections or other infectious causes of proctitis that we see. So I think what I'm going to be sort of looking for as we reach through this case is, can we start to match any of the other elements of this gentleman's HPI with some of the things that we might expect to see with some of these diseases that we mentioned? Is there a history of recent constipation and large bowel movements that may increase the risk for anal fissures? Or is there a history of receptive anal intercourse that may also increase the risk of the development of fissures? Do we see a coexistence of abdominal pain and bloody bowel movements that may increase the probability of there being underlying inflammatory bowel disease? So I think we're sort of trying to distinguish, is this proctitis? Is this going to be a structural lesion within the anal rectal tissue, like hemorrhoids or an anal fissure? Is there an underlying malignancy that's developing, such as, for example, anal rectal cancer? And again, we're going to use these other elements of the HPI to sort of prioritize these differentials. But I think two general categories that we could think about is like there is inflammation of the area, or there is a structural lesion of the area. The inflammation could be things like proctitis, inflammatory bowel disease, or cancer, or there could be a structural lesion here from something potentially related to this individual's sort of just general behaviors, or related to an underlying gastrointestinal disorder.
Awesome insights, everybody. I think Bill's going to give us our next aliquot. I know if this complaint shows up in the ER on the tracker board, I'm thinking thrombosed external hemorrhoid, fissure, or a perirectal abscess. But this is VMR general, so I guess we'll have to see. All right, Bill.
Thanks, Travis. So for the HPI, anorectal pain started 7 days prior to presentation and progressively worsened to where he could no longer sit. He also noted that he had some mild abdominal pain located in the left lower quadrant / the inguinal area. He reported intermittent bright red blood when he wiped that started 3 days prior to presentation. He had additionally reported decreased oral intake over the last week in the development of looser brown stools that were intermixed with bright red blood. When the pain escalated to 10 out of 10 and the bleeding persisted, he then presented to the emergency room. Some review of symptoms. He denied weight loss, fever, night sweats, denied loss of bowel or bladder control, denied rashes or skin discolorations, no nausea or vomiting, and denies arthralgias or myalgias. And a couple more negatives. So past medical history, no past medical history, no past surgical history, no family history of inflammatory bowel or GI malignancies, no medications, and social history, no tobacco, alcohol, or drugs. And he reports unprotected vaginal and anal sexual intercourse with women only. And his occupation is a local party DJ with no recent domestic or international travel.
Amazing. Thank you so much, Bill. Just to give the audience, everybody tuning in a chance to sort of think through this, I just wanted to clarify. So the primary symptoms were mild abdominal pain in the left lower quadrant, loose stools, some of which were occasionally bright red and bloody. Is that right?
That's correct. And then he came to the ED because the pain was 10 out of 10 and he continued bleeding.
Okay. And was there bleeding in the absence of stools, or he just noticed the blood when there was stooling?
We don't know, but we know that it was intermixed with bright red blood in the stools as well.
Okay. So I'm curious to hear, we have, I think the interesting findings that are really standing out here is that we have this syndrome of abdominal pain and loose stools in addition to the anorectal pain and bleeding. And I'm seeing some people start to sort of share some sort of synthesis of this, particularly Kushal mentioning how LGV, gonorrhea, and HSV are now coming into play more. Kushal, do you mind sharing a little bit more about sort of how you started to think more heavily about incorporating those infections into the DDX here? And Kushal, no worries at all. I'm gonna come to you instead, Hans, mentioning how ulcerative colitis is seeming possible now based off of this history.
Yes, but I would like to learn from Kushal because it's a very interesting thought that he brought up. We mentioned inflammatory bowel disease earlier and the possibility of ulcerations at the anal area. Now he has loose stool. He has bleeding from the anus. So this looks very much like an inflammatory bowel disease as well as one of our differentials. So let's see what else is coming up. Now, the fact that he has mainly intercourse with women probably makes it less likely, but I can't really tell that there are sexually transmitted diseases such as HPV, but we shall see. So it's all open right now.
Yeah, no, I think that it's that it is an excellent point, Hans. I love that, right? So I think just to sort of name what at least is happening for me in my brain as I'm hearing these chief concerns is that there is a clinical syndrome emerging that potentially extends beyond just the rectal area, right? Usually if we have proctitis alone, we wouldn't always expect there to be this findings of things like lower quadrant abdominal pain or loose stools. because those are usually things that are going to involve either the small intestine or the colon. So we may have something like proctocolitis, which has its own DDX, or something like enteritis, right? Both of those syndromes can present with abdominal pain, cramping, diarrhea, and rectal pain, but proctitis alone doesn't always, but it certainly can manifest with that, right? Is the finding of left lower quadrant pain in and of itself enough to say we are 100% not dealing with the rectum only? No, it's certainly not, right? Many inflammation in one area can certainly send pain other areas. We see this all the time, right? And I actually I have seen a case previously of someone who just had ulcerative proctitis, who actually had also left lower quadrant abdominal pain, but there was actually no colonic pathology that was found on endoscopy, right? So I think we are having the specter of something that extends beyond the rectum come into play here, but certainly this hasn't been a definitive finding. And again, that matters because if we're thinking about inflammatory etiologies of a disease that includes the rectum, but extends beyond the rectum into the colon, certainly something like ulcerative colitis begins to come into play. And then also if we're thinking about infectious diseases that are going to involve the rectum and the colon, we might start to think about some of the more invasive bacterial infections, things like Campylobacter, Shigella, Yersinia, or some of these other pathogens, rather than those that just involve the rectum, things like HSV, LGV, chlamydia, and gonorrhea, right? And so I think that this finding of the abdominal pain here is useful in terms of informing what potential diagnoses we bring into play, but it by no means is carries a huge diagnostic weight that we can now anchor on going forward. I see Sonia mentioning again one of her GI attendings talking about how Crohn's more often causes abdominal pain and UC causes bloody diarrhea that may lack some of the pain. And I'm curious if anybody else has sort of heard of this disease association. And I think that like this brings up a really tricky question, which is like, how much diagnostic weight do some of these symptoms carry over other findings that we may find, right? I think in a case like this, the exam and the imaging are probably going to carry much more diagnostic weight for me than these symptoms. Because if we see a big abscess in the perirectal area, as Travis mentioned being a possibility, right, we are going to think very differently about that than if we see colitis on a CT scan in someone like this. And so I think, right, we have to be open to the fact that while these symptoms are helpful in terms of thinking about where we focus things, none of them for me probably carries the diagnostic weight of saying that we can exclude one set of pathologies and prioritize another. It's just sort of is going to be sort of evolving in the soup of how we're thinking about this. So maybe I guess just to sort of summarize where we're at, right? We were initially thinking about something that involved the rectum. We then got this other information that there was lower quadrant abdominal pain and some loose stools and bloody diarrhea. And that brought in the possibility of there being a proctocolitis into play or a enteritis into play, and that we're just seeing the manifestations of this in terms of the bloody diarrhea. And we talked about how proctitis can have primarily an infectious or inflammatory DDX, and then other pathology limited to the rectum might be things like a rectal abscess or fistula, an anal fissure, or hemorrhoids. But then if we're going to extend beyond the rectal space and start to think about proctocolitis, we might think about other infections, right? Things like Campylobacter, Yersinia, Shigella, or continuing to think about inflammatory bowel disease here. So I think, right, the exam is going to be super helpful in terms of what we see on rectal exam, and then potentially also using cross-sectional imaging if we're going to ultimately go down that route. And maybe I'll turn it back over to you, Travis and Bill, for more information.
Okay, thanks, Jack. So for the physical exam, vital signs, temperature of 36.4 degrees Celsius, a heart rate of 100, respiratory rate of 18, blood pressure of 130/72, and O2 sats at 99% on room air. In general, he appears uncomfortable in the bed, but he's in no acute distress. The Hint exam shows pupils that are equal, round, and reactive to light and accommodation. No thyromegaly or nodules. Normal dentition. No oral ulcers. Lungs are clear to auscultation bilaterally. without wheezes, rales, or rhonchi, and there's normal respiratory effort. Cardiovascular, regular rate and rhythm with no murmurs, rubs, or gallops, no bilateral lower extremity edema. Abdominal shows so soft tenderness to deep palpation in the left lower quadrant, and it's non-distended. Bowel sounds are present in all 4 quadrants. No external hemorrhoids, fissures, or rectal tears are appreciated. And there's severe pain elicited limiting digital rectal examination. Musculoskeletal exam is normal, and skin shows no rashes or discolorations. And some labs. White blood cells are at 7.3. Hemoglobin at 14.6. Platelets at 322. And sodium at 142. Potassium 4.4. Chloride 107. Bicarb 25. BUN 20. Creatinine 0.93. Glucose 99. AST 21. ALT 34. Total Billy 0.9. Alk Phos 85. Total protein 6.9, which is normal. Albumin of 4, which is normal. UA is negative. CRP is normal at 3.2. ESR elevated at 33. Lactate is 1.6.
Thank you, Bill, for giving our feverishly working scribes time to fill in some of this information. Were there any other labs or imaging that you wanted to include in this aliquot?
No, that'll complete the aliquot.
Okay, awesome. Well, I'm seeing some like phenomenal things coming in the chat here, and I just want to highlight. So, like, I think where we're at even before this aliquot is sort of grappling with: are we dealing with a clinical syndrome exclusively of a rectal problem, or are we dealing with a problem that extends beyond the rectum and into the rest of the, or into some other areas of the intestinal tract? And Deborah has given a brilliant summary here of some of the ways that we can potentially differentiate or frame the probabilities of some of the inflammatory bowel diseases, which we included within both rectal issues alone and rectal issues that extend into the rest of the intestinal tract. Deborah, do you mind unmuting and sharing a little bit more about what you put in the chat in terms of some of the differences in the clinical manifestations of UC and Crohn's?
Yeah, I found on Google, I don't know if that is for sure real, but like what I found was that the UC, the patient can have more pain, and then from chronic, that makes the difference about chronic disease. That can that the patient can have more bleeding in the chronic disease, but in this case, the patient have both. So I don't know how to make the difference.
Yeah, no, it can be incredibly challenging, right? These are two diseases that sort of exist in one category and have some distinguishing features, but also have a tremendous amount of overlapping symptoms. And so oftentimes we rely on things like colonoscopy and biopsy to determine whether we have Crohn's or UC. But some of these clinical features that you mentioned map onto what we know about the pathology, right? Ulcerative colitis is usually a disease process that involves the colon alone and continuous inflammation. So it's more likely that we're going to have left lower quadrant pain, whereas Crohn's disease can impact many areas of the small intestine, which may lead pain to manifest in other areas. There's a particular predilection for the terminal ileum, which often in most individuals will be somewhere around the right lower quadrant. So these sort of pain profiles can help us think about things. And it's important to remember that of those two inflammatory bowel diseases, ulcerative colitis is the one that is the most likely to involve the rectum, right? So if we're sort of thinking about right, how are we framing the probability of either of the inflammatory bowel diseases based off of what you just told us? Ulcerative colitis seems more likely than Crohn's in this specific clinical syndrome, but we still have to carry that against the other categories of disease that we mentioned, particularly infectious diseases here. And then I see Shreya mentioning about how their differential is going more towards fissures in this case. And I'm curious, Shreya, how are you integrating some of these exam findings into thinking about increasing the probability of fissures in this case? And totally okay if you're not at a place to unmute and share more. Well, maybe I can turn it over then to Rafa instead. Rafa, I think you also mentioned a really important sort of reasoning pro here, which is how some of the extra intestinal findings that we do or don't have here are framing your pretest probability of something like IBD in this case. Do you mind unmuting and sharing a little bit more?
Yeah, I was thinking that in inflammatory bowel disease, we would expect like dermatological manifestations, also rheumatological manifestation, and this patient doesn't have any. And we also have like very reassuring labs. Someone already mentioned that. So for example, normal hemoglobin, normal platelets, and I would expect like inflammatory bowel disease, at least anemia of a chronic disease, which are something that we're not seeing here. And also more elevated CRP and ESR, marks of inflammation, you know. So that makes me go away from IBD at this point.
I think excellent, right? So I think the sort of general reasoning pro that Rafa is using here is this idea of, right, how we are comparing the illness scripts that we have of the diseases under consideration against the illness script that our patient is presenting with. And many of the features of our illness script for inflammatory bowel disease, whether that's UC or Crohn's, is going to involve extra intestinal manifestations, whether that's things like joint pains, uveitis, sacroiliitis, back pain. Other findings that we notably don't see here can alter the probability of that specific diagnosis in our patient whose illness script is predominantly localized to the GI tract and the rectal area, but also whose illness script has a tempo that is maybe shorter than what we would expect with a more indolent disease like IBD. I think one of the things that this exam is doing for me is it's really prioritizing the center of gravity on the rectum, right? Yes, we have some palpation in the left lower quadrant, but it's totally plausible that that's just related to the rectal inflammation. But what's really jumping out to me is the things that we do and don't have on the rectal exam, right? We see exquisite tenderness to palpation during the digital rectal exam, which is a hallmark signature of the clinical syndrome of proctitis. And then we also notably see other things on the rectal exam. We don't see external hemorrhoids. It doesn't rule out the possibility of internal hemorrhoids, but we at least don't see external hemorrhoids. We don't see fissures, and it sounds like we didn't see a perirectal abscess, at least on gross exam. It's important to note that our gross examination of the rectum is going to be limited because there's a large portion of the rectum that we just can't see based off of direct observation. So there could be an abscess or fistula deeper inside the rectum that we can't see on external exam, or there could be internal hemorrhoids that we don't necessarily see. Oftentimes internal hemorrhoids will bleed but are less painful, whereas external hemorrhoids will be oftentimes much more painful. But Travis mentioned the possibility of a thrombosed internal hemorrhoid, which can be exquisitely painful and difficult to see just based off of our gross exam. But if we entertain the possibility that what we are dealing with is indeed a syndrome of proctitis, right, we can start to sort of continue to refine these two disease categories that we mentioned, either infectious proctitis or autoimmune/inflammatory proctitis. Ulcerative proctitis being the most common auto-inflammatory process. And then the infectious DDX is quite long, but includes things that Kashal has put in the chat and other things that we mentioned here, right? So that seems like it's the predominant clinical syndrome of proctitis rather than one of the other mechanical lesions that we saw, but we have to at least be humble and open to the fact that there's something inside that we just can't see yet. So we have that one diagnostic hypothesis that this is a case of proctitis. And then we have the other diagnostic hypothesis that the lower quadrant abdominal pain and the loose stools aren't just reflective of referred pain from the rectum, but are actually reflective of there being coexisting colonic inflammation, so a disease process of proctocolitis. While the infectious DDS shifts with proctocolitis to things that we mentioned, Campylobacter, Shigella, E. coli, Entamoeba histolytica infection, the inflammatory DDX doesn't change that much, and we still are going to think about things like ulcerative colitis, which again can have proctitis, colitis, or both coexisting at the same time. So the question then becomes, well, where do we go from here? And I think if we prioritize our clinical evaluation, we want to get a better look at the parts of the rectum that we can't see from our gross exam to look for things like, is there a internal hemorrhoid within the rectal vault? Is there a fistula or an abscess inside the rectal vault that we can't see yet? Is there potentially a mass within the rectal vault that we can't see yet causing pain? Or do we just see rectal inflammation that is going to be a signature of proctitis, right? So that's going to be, I think, step one is, can we do something like anoscopy to get a better view of whether there's a lesion or a problem in the rectal vault that we just can't see on gross exam, but that gives us the answer. And that would be something like a mass, a fistula, or an abscess, or a hemorrhoid. And then we also have to ask ourselves, how much further do we want to explore this left lower quadrant abdominal pain, right? If we do we want to entertain the possibility of there being coexisting colitis and look for it with a CT scan? Or do we feel like actually all of this is just localized to the rectum and we can get an understanding of the pathology that's there based off of the anoscopy alone? You know, I think in this case where I would probably go, given that we don't have things like a super high white count, we don't have super high fevers, there's not a clear signature of something sinister or really severe happening within the abdomen, I think would probably prioritize the anoscopy at this point, because that seems to be where the center of gravity is, both in terms of looking within the rectal vault, but then also thinking about what types of testing we could send from a specimen from that area, right? So we could swab and look for many of the STIs that we mentioned, HSV, LGV, gonorrhea, and chlamydia being some of the higher diagnostic yield ones to go for. And then if those come back negative, then I think we may then have to explore the possibility that actually is this a non-infectious inflammatory disease process, something like proctocolitis or ulcerative proctitis alone. And that's going to potentially involve something like a biopsy or colonoscopy or more advanced studies. But if we can find a plausible answer here from anoscopy alone and feel like everything can be explained by the rectal inflammation, that could save this patient potentially invasive diagnostic tests. But if that path of exploring infections in the rectum alone is unrevealing, then I think we have to extend the workup and potentially with a CT scan or colonoscopy. I'm super curious to hear where the clinicians went in this case. But before we do that, I noticed I want to make sure, Sonia, you mentioned sort of very, very early on thinking about a CT scan here, and I'm curious what the features were that made you feel like CT was going to be useful early on in this patient, because I too am grappling with how and when that would fit into the diagnostic workup here.
I think to me, the fact that there was a positive finding on the abdominal exam, which is non-specific and doesn't really help us make diagnostic progress, but indicates that there is something going on maybe nearby, sort of raised my suspicion, especially with normal labs. I think about what kinds of things might be hiding and we might not necessarily see in terms of systemic manifestations like anemia or a white count. And so like the tenderness to deep palpation, although it could theoretically be explained by a local process, could also be sort of a hiding deeper process and could hint at involvement further up along the GI tract. And so that was kind of my thought with what other kinds of things might be hiding from us that we can't necessarily see, particularly with this exquisite tenderness that doesn't allow us to do a good physical exam internally along the mucosal lining of the GI tract.
Yes. I think that is such a brilliant point, and again, is going to be so important if we do or don't see something in further exploring the rectal vault, because we may find something on that could explain proctitis, but we may still be left without an explanation for this left lower quadrant abdominal pain and the loose stools, right? And I think that like where we set that CT scan threshold is something that we could probably agonize over, but I think you're spot on that like realistically, it's going to be hard to close the book on this case without at least taking a better look at what's causing that left lower quadrant pain. And our first pass to do that would most likely be a CT scan. So Bill and Travis, I'm anxious to see where do we go from here, and where did sort of the rest of the diagnostic workup take us?
Definitely. So we get the CT scan, we get a CT abdomen pelvis with contrast that shows mesenteric stranding near the rectum with several enlarged mesenteric lymph nodes surrounding the rectum. But it's an otherwise normal CT abdomen pelvis with no evidence of colitis or neoplasm. We get a colonoscopy. Danny, are we caught up in the scribing? I want to make sure we're inclusive. So the colonoscopy showed localized moderate inflammation characterized by erythema, friability, and granularity involving the rectum secondary to proctitis. Histological evaluation of rectal biopsy demonstrated acutely inflamed, eroded colonic mucosa, and a Wharton Starry showed bacteria that represent normal flora, but no definite spirochetes. And we get some additional labs: HIV negative, acute hepatitis panel negative, ANA negative.
Next one, HSV.
Yeah, HSV negative, CMV negative, CEA negative, stool culture negative, C. diff PCR negative, anti-Saccharomyces cerevisiae antibodies negative, and fecal calprotectin negative, and that completes the aliquot.
And there's just one more bit of information that will be the diagnosis next. So
awesome. Well, I'm super curious to hear from the group, right? So this is a super useful aliquot because we have finally been able to define the clinical syndrome that we're dealing with, right? We got that CT scan that shows us that this is indeed a problem that is solely limited to the rectal area, right? So like we had some suspicion, right? We sort of were building a case throughout the history, the physical exam, and now the imaging for a syndrome of proctitis. And that indeed seems to be what we have here. And then we then got a whole host of potential of labs that help us to potentially, decrease the probability of some of the diseases or framing factors here. But I'm super curious to hear from the group. How are you all thinking now about this young gentleman who it sounds like has had unprotected vaginal and anal intercourse with women, who's coming in with a syndrome really of acute proctitis with mucosal friability on colonoscopy and no clear infectious agent identified on the biopsy. I see Xavier mentioning LGV due to lymph nodes is a possibility. Xavier, do you mind sharing a little bit more?
Thank you. Yeah, I was thinking lymphogranuloma venereum, since I don't recall exactly, but I don't think you can isolate the agent on on a sample of a swab, I think you need to go after the lymph nodes or doing serologic testing. So that could be a possibility given the history of unprotected sex and all the findings that we see.
Yeah, great, excellent point. Right, so certainly LGV, which is a disease caused by many of the different chlamydia serovars, as being sort of one of the potential things that can cause proctitis with this coexisting lymphadenopathy. We may expect to see ulcers, rectal ulcers in someone who has LGV, but their absence certainly does not rule it out. And if we were then to think about, well, gosh, what is the inoculation going to come from in terms of thinking about LGV proctitis or chlamydial proctitis, right? It's usually from receptive anal intercourse, which it sounds like this gentleman didn't have, but we can also have dissemination from from genital or inguinal disease, right? And so this is a case where it would be useful to ask the patient, does he recall having any genital ulcers? Does he recall having any inguinal lymph node swelling? Because while he may not have risk factors for the development of proctitis alone, there certainly could be the development of proctitis as a result of genital disease from penetrative vaginal intercourse. And so I think, right, that becomes something that certainly comes on the list here. I'm curious from the group, what else are people thinking in terms of these findings? Who can make a case for a non-infectious process here? Nate asking the question of, can we have reactive lymphadenopathy with IBD, which I think is sort of highlighting right there. We have not only the finding of there being proctal inflammation, but also the coexisting lymphadenopathy. And I would say, Nate, I tend to agree with you. I certainly think, right, if we have inflammation somewhere, if there are lymph nodes nearby, it's totally plausible for those lymph nodes to get inflamed. So I'm having a tough time deciding whether the lymphadenopathy is a key clinical finding or just a bystander finding of the proctitis that we eventually see. So I'm with you. I think I probably am sort of holding both hypotheses, that the lymphadenopathy is a characteristic feature versus just a reactive specimen. And I think one of the things that I'm noticing in terms of the colonoscopy is that, right, the mucosal friability, as well as the fact that we don't see necessarily infectious agents on exam, has to make us think about ulcerative colitis or ulcerative proctitis here, right? One of the variations of ulcerative colitis, but we oftentimes can't settle on that diagnosis until we formally have excluded all of the potential infectious etiologies, which we have by no means done here yet, right? So evaluating for the different chlamydial serovars that can cause LGV, critical. Evaluating for gonorrhea, which it seems like we haven't, which I may have missed, right? But we're certainly going to do gonorrheal testing. We're going to potentially look for entamoeba histolytica infection. I think Travis has brought that as an STI to us before. It seems like HSV is negative on serum testing, but that doesn't necessarily mean that we're not dealing with HSV within the rectal vault, although we don't see the characteristic vesicular lesions that we might expect to see for HSV. And then also making sure that we don't forget one of the rare but certainly possible manifestations of syphilis, which is syphilitic proctitis, right? And so syphilis can certainly cause rectal disease, either related to primary, particularly related to primary infection, but also during other phases of the disease. And so again, I think we may end up settling on a potential autoimmune or inflammatory cause here, but that's going to be at the exclusion of these potential infectious agents that this person is at risk for, which is going to primarily include the STIs that we mentioned, but then also potentially rarer causes. I know that Kushal mentioned things like endemic fungal infections that could potentially manifest this way in somebody who has risk factors. And so I think, right, we may be going towards a diagnosis of ulcerative proctitis, but certainly we have to rule out LGV, gonorrhea, syphilis, HSV, and some of these other STIs before we get there. So I think that's sort of how I would hold this if I were to be honest, right? I wouldn't be surprised if we end up with a diagnosis of ulcerative proctitis, but I also wouldn't be comfortable settling on that diagnosis until we have excluded with reasonable probability some of these other infectious agents that can cause proctitis.
Hey, Jack, before we give the final aliquot, I would say that, given like the information, in the ER, I don't always get all this information. So, I've got a 27-year-old guy who's got anorectal pain, CT scan shows stranding, nothing other red flag symptom, then I'm going to have to keep him. So I need to make a decision. Hey, what am I going to do with him before I can get him followed up with GI? And I think, the absence of some of this information, I would really just treat this guy for, proctocolitis, because it's possible he got a tear in his, uh, distal rectum, and we have bacteria there, and maybe he's got an E. coli, just like a proctocolitis from E. coli. I probably would give this guy Augmentin or, Flagyl and a cephalosporin and have him follow up and see how he does. Where, this case progresses to be something else, but that's usually how I probably would treat this in the ER. Obviously if he was sick and septic, I would keep him, but that's, more than likely would be my disposition from the ER pending all of these other tests. So that's where I would go with it, on my side of it. And, just before we get to the final diagnosis, this case will be a human DX case. It's by Jennifer Mundell. She's a hospitalist at Ascension up in Indiana. And she's presenting a clinical unknown case at the end of the month on the CP solvers to Elliot Tapper. So she has tons of really good cases. And so I hope you all enjoy the final diagnosis here. But if you don't have anything else to add, I'll have Bill take it away. All good?
Go for it, Bill. Yeah.
Okay, so we get our final labs. We get a quantitative RPR. It is positive at 1 to 128. A quantitative VDRL, positive at 1 to 64. And FTA, ABS, IgM, and IgG are positive. And so we get a final diagnosis of syphilitic proctitis. This gentleman was treated with intramuscular penicillin G for 3 weeks, and his post-treatment quantitative RPR titer 2 months after treatment was completed was 1 to 8 with a resolution of his symptoms.
Amazing. There it is. Right. Can never forget syphilis. I'm curious, Travis or Bill, if either of you know, did they think that this was primary syphilis, secondary syphilis, or it was too difficult to tell?
I think they thought it was primary. That is my guess, but I think this also can present as secondary syphilis as well. After reading, she had some teaching points in here. Bill, did you want to run through them really quick? Because we did discuss that. Is that okay, Jack? If he just goes over some teaching points?
For sure.
Okay. Bill, you want to read those as well?
Yeah, definitely. So a little bit of like epidemiology as well. Syphilitic proctitis rarely reported, but is recognized more frequently with the increasing incidence of syphilis among men who have sex with men. A retrospective review of clinical proctitis affecting MSM revealed that syphilis is found in 2% of cases. Syphilis proctitis can occur either in primary or secondary syphilis. Involvement of the gastric mucosa, terminal ileum, and colon have also been reported as sites of syphilis infection. Most common symptoms of syphilitic proctitis are hematochezia, tenesmus, mucus discharge, and changes in bowel habits. Systemic symptoms like fever and lymphadenopathy may also occur. Multiple biopsies are recommended because standard histological evaluation may be non-specific. A negative test on biopsy does not rule out syphilis, and most of the authors have postulated serological testing sufficient for diagnosis. Diagnostic testing for syphilis infection consists of the nucleic acid amplification test for Treponema pallidum DNA from the exudate out of an ulcerated lesion if present. Serologic tests include RPR, VDRL, and FTA antibodies support the diagnosis of syphilitic proctitis. Due to the difficulty of visualizing a causative organism on biopsy, diagnosis is then achieved by the combination of clinical presentation, serologies, and endoscopy. The treatment, like I said, so initial treatment of choice for syphilitic prostatitis is benzylpenicillin or penicillin G, 2.4 million units in 1 intramuscular injection. Patients may require a dose repeat at weekly intervals for 3 weeks because of the possibility of a latent syphilis infection instead of an early primary infection. Patients with a severe penicillin allergy are treated with oral doxy 100 milligrams twice a day for 14 days, or tetracycline 500 milligrams 4 times daily for 14 days. Follow-up rectal exam and serologic testing should be completed at 6 and 12-month intervals after treatment. It's imperative for healthcare professionals to consider syphilis and other sexually transmitted infections, including HIV, in patients presenting with rectal symptoms, and a detailed history, including sexual preferences and practices, can be crucial in establishing a diagnosis. And that concludes the teaching points.
Thank you so much, Bill and Travis, for a phenomenal case. I want to turn it over to Brody to take us through the final teaching points before we sign off. But this was an awesome case, and I think really highlights how challenging any of these inflammatory GI symptoms can be, anywhere from the esophagus into the rectum, in terms of how infections and autoinflammatory diseases can look so much alike. And oftentimes we can't settle on the autoinflammatory disease until we have formally ruled out all of the different infections that could potentially be there. But Brody, take it away.
Great case. Yeah, tried to synthesize most of it, but I guess let's see. Elements of problem representation include the symptom and the syndrome and the host features, and something I guess we should keep in mind for all cases. Then specifically anorectal pain and bleeding could be approached in anatomical or an etiological way. Anatomical could be the vessels, hemorrhoids, or mucosal could be proctitis, or something as bad as probably abscess. And then etiological could be infectious, HSV, gonorrhea, which is a good portmanteau, which Sonia gave us. And then there's the STIs, which could also involve entamoeba, and therefore also not forget syphilis. Inflammatory, IBD, then there are and malignancy, mechanical or structural, as you said, which could also include fissures. Inflammation in one area can trigger pain in adjacent areas, which is what you said, Jack. And abdominal pain could also be possible in rectal pathologies in the absence of a colonic or other, small intestine problems. Then IBD, bloody diarrhea, is more common probably in ulcerative colitis than Crohn's, which is more watery diarrhea. And then for IBD, look for its extraintestinal manifestations, which could include skin, pyoderma granulosa, erythema nodosum, eyes, uveitis, episcleritis, mouth, aphthous, ulcers, joints, spondyloarthritis, and enthesitis. Some IBD mimics could involve infectious causes like LGV, TB, histo, paracoxy, and also non-infectiously solitary rectal ulcer syndrome. LGV, genital ulcers, which can be present or cannot be, and then along with inguinal lymphadenopathy. However, the absence of ulcers does not rule out the diagnosis. And then I guess I had the last bit about syphilitic proctitis, which I'll just rather not repeat because Bill went over it already. So that's it.
Amazing. Thank you so much, Brody. Those were absolutely phenomenal teaching points. Thank you again, Bill and Travis, for bringing such an excellent case. And I want to thank everybody who contributed such awesome thinking and reasoning to the chat. It was such a blast to get to think through this case with you all. And I will say I am incredibly proud of the way that everybody was sort of on the scent of the case from the get-go. Even from the first line, we had people talking about infectious versus an autoimmune disease, which is just brilliant reasoning and synthesis. So thank you all so much. I look forward to seeing hopefully many of you at the next VMR, and hope you all have a wonderful day. Thanks, team.